their recovery, but we're also working with them to prevent future violence. So we're looking at this as a cycle, and we are one piece of that in the healthcare sector. So what happens when gun violence meets COVID-19? I think that's really one of the most important questions to start to look at. We know that victims are going to continue to arrive at our health system with critical wounds that are going to need many of the same vital resources that our patients with COVID-19 are going to rely on. So there could possibly become a competition for scarce resources depending on how advanced COVID-19 is in your own communities. So we're talking about resources like PPE, like ventilators, the blood supply. Violence isn't going to slow down. It's going to continue to happen within our communities. In fact, in most cities across the United States, especially those that are larger, and in Virginia as well, while other crimes we've seen a decrease in those rates, the rates of gun violence have either increased or remained very steady for this time period. We don't have enough documented evidence to know how or if it will increase during a pandemic, because this is somewhat new territory. But what we do anticipate is that it's going to continue along the same trajectory it usually does. And especially because it's getting warmer out. So unfortunately, warmer weather tends to show an uptick in violence. So what we see is that more people are going outside despite social distancing. Kids are out of school. Everyone's home together. We expect to see the rates of gun violence in particular start to rise sooner than they would usually. Most of the time we see our rates of gun violence start to uptick after Memorial Day, but we've already seen that start to happen in our own communities. Let's go to the next slide. So hospitals provide a real unique window of opportunity. We are the one place where you're going to be able to put your hands on somebody who is in a vulnerable place. You're talking about that young man who had a gunshot wound injury, who is sitting in his hospital room, most likely alone, feeling vulnerable, having feared particularly probably for his life. What other opportunity does anyone else in the community have at that particular moment to walk into a room and say, I have resources, how can we help you? How can we provide support so that you don't come back to see us again? We look at hospitals sometimes as, a revolving door, but we don't have to be. You can go to the next slide, please. Oftentimes, hospitals end up doing treat to street to treat again, meaning that we bring somebody in, we patch them up, we send them back out again, and more than likely, they're going to walk through our doors again, whether that's for another injury that's just as severe, or we're sending them out to then have a higher rate of mortality. So we like to think of hospitals can play a different role in this aspect. So we know the 5-year re-injury rate for victims of intentional injury, so that's talking, gunshot wounds, stabbings, and assaults, is somewhere between 10 and 50%. And we know it's actually closer to the 50% mark than it is the 10, but it is a range. So of all of those survivors that you are treating and sending back out into the street, the likelihood that they're going to return is very high. 20% of those are estimated to die as a result of subsequent violence. So we treat them, we say they're patched up, they're ready to go, they're healthy again. We expect that they're going to make different choices, but they don't, and they don't have the ability to do that. They don't have the resources to do that. So we can play a role in helping to reduce that mortality rate. When we look at our own numbers at VCU Health through our trauma registry, what we're seeing with patients that we aren't intervening with is about a 15% re-injury rate, sometimes a little bit higher. While we anticipate, making sure we intervene with all of our patients, there are times where we miss a patient because they come in at a time where we're not available, or before our program was really established, we saw this with just about every patient that we came in. It's about a 15% re-injury rate. And we anticipate that that is expected. That's actually expected across the board. It's what most hospitals and trauma centers are seeing across the United States. So it's not just talking about Richmond and VCU. This is talking about hospital systems across the nation. You know, we see about 4,300 trauma admissions per year, and 12% of those are firearms and stabbings. And while that may not seem as a high percentage when you look at, motor vehicle crashes or the rise in elderly falls, but what we do know is that the lethality of these injuries is so much greater, and the re-injury rate is so much greater. So this is why the hospital can play such a strong role in making sure that our community members have the resources that they need to be safe. I apologize, I'm working from home and the doorbell rang. Davis, if you could go to the next slide. So one solution to helping our community and working with the community is hospital-based violence intervention programs. That's something that we have established at VCU Health. We have an evidence-based program, or an HVIP. And what that means is that we have a multidisciplinary program that brings together our hospital staff with trusted community partners that provide safety planning, wraparound services, and trauma-informed care to our patients who are violently injured. Our goal is really engaging our patients at the hospital during their recovery. That window of opportunity that I spoke about, it's a golden opportunity to improve lives and reduce retaliation and recidivism. So one of the main components of that is employing case managers to work hand in hand with patients and their families. And we always put family in this as well, because, and family can be chosen family too. So we don't mean just parents or siblings, but we're talking about the people that support the patient as well, surrounding them with the services that they're going to need to help make healthier decisions as they move forward. So that's connecting them to some of our most important community resources. So those for mentoring, early childhood education, housing. Housing is a big one. Crisis intervention, providing that at the bedside, connecting them back into the educational system. Maybe the person dropped out of school but still wants to get the rest of their education. So connecting them to GED resources, or connecting them to a community college or four-year college. Legal advocacy. The idea is that we are taking this family, walking hand in hand with them to make sure that there's warm handoffs between our case managers and their next step, and that we continue to follow the patient as they progress through their service plan, because that's what we end up creating with them. Go to next slide. So at VCU Health, we have Bridging the Gap. And Bridging the Gap is our hospital-based violence intervention program, where we provide intensive case management to patients who are either admitted or come in through our emergency department for gunshot wounds, stabbings, and assaults. And what we do is we provide that intensive case management while they're at the bedside, especially for those who are admitted, because we'll have more time with them. But finding out what do they need, doing a full assessment, connecting them with our case managers, connecting with their family, with their friends, with their partners. But the secondary step that I think is really important is that we then connect with them post-discharge, and we follow them for up to a year to make sure that they have somebody that's on their side helping to guide them through the goals that they've set for themselves. We are not setting goals for our patients, but we are working with them to create goals that make sense for them so that we are reducing the rates of re-injury, retaliation, and mortality. And we're hoping to create a sense of safety and hope within their own household. So part of looking at creating a hospital-based violence intervention program, or even if you don't have the ability to do that right now, one of the most important steps you can take to help serve victims of intentional violence is really understanding your community. knowing where those patients are coming from, knowing what barriers they're facing, understanding what that community looks like and is made up of. So when we look at our VCU health patient population, especially those that we are seeing in our Bridging the Gap program, Richmond City itself has a very large minority population. I believe it's 49% African American, and that sort of drives how we serve our programs. We know that there's a huge discrepancy in life expectancy depending on what zip code you were born into and grow up in. If we look at the city of Richmond in particular, there is a 20-year gap between our 23223 zip code, which is our east end of the city, and our zip codes that cover the west end of our city. So our 23223 zip code life expectancy is somewhere around mid-50s, whereas if you look at the west end of our city, we're expecting those that live there to have a life expectancy well into their 70s. And that's partially because of unequal wealth distribution. Inherent racism has played a part in how the city has been spread across those socioeconomic statuses as well. We have a high number of Title I schools in our district, meaning that most kids receive some type of assistance through school, so whether that's free or reduced lunches is one of those measures. We are in a food desert. Richmond City, especially in our neighborhoods of need, has a high level of need for grocery stores. We know in our East End, which is our most at need population, there is only one grocery store, and that grocery store opened only about a year ago. Before that, it was at least a 20 to 45-minute trip to a really good grocery store have access to the foods that maybe you or I might have access to. Other than that, most of our residents and our community members were really forced to go to their community, to their corner store to get nutrition. And then lastly, we have high rates of intentional injuries and violence. And that's how we've looked at focusing. It's really looking at the social determinants of health, looking at where those social determinants of health have some of our lowest outcomes, and figuring out where are those areas and how do we best help those patients. So really understanding your own social determinants of health for your community is going to be incredibly important as you continue to build your programs or as you continue to serve your patients. And Davis, I know you have some tools that might help our hospital partners to figure those things out.
Sure, thank you, Amy. I do want to mention just something that we've provided to our subrecipients for our grants, or are going to be providing for our subrecipients for our grant. And VHHA data analytics team has built a data portal for our subrecipients that includes injury data as it relates to violent injury. And we know that understanding your community and understanding your patient population is a lot easier said than done, and we want to help our subrecipients do that. And I think that's something that we've really worked hard to build and understand, help them understand. We're also working to build in Z-code data, which is that social determinant of health data into the data portal as well, so that you can help to kind of see the root causes in those zip codes as well. So you can really get that full picture that Amy was just talking about. And that's something that we're helping to provide to our subrecipients as well, to help them better serve their patient populations and do a little bit more smart intervention as we move forward in implementation.
So if you understand your patient population, it really makes it a lot easier to understand what your community's needs are. So some things to look at, especially during our COVID response, these are the things that we think would be really helpful for you to focus on to best help your patients in the now. Even without having a hospital-based violence intervention program, these are resources you should be able to access or help your patients to access. So number one is student support while schools are closed. We know that especially in our highest need areas, kids don't have the same access to resources. So they may need help getting educational supports. So it might be connecting them to their school system to help them get the iPads that schools are giving out, or the laptops that schools might be giving out, helping them to find access to Wi-Fi or internet services, and then also meals. A lot of our kids are, because they live in food deserts, because they don't have, their parents don't have the means to get enough food on the table to feed everyone, rely on schools for meals. Most schools across the state are still providing at least some type of pickup meal for families. So looking into that, or what other options that schools might be providing for their students. Childcare for essential workers. So our essential workers are, even just thinking in your hospital system, our cafeteria workers, you know, those that are in environmental services, nurses, care partners, people working in food industry. If they can't find childcare, how do they work? So they are more at risk if they can't find childcare for needing to make decisions that might lead down a path that is more dangerous. Housing resources. Housing is a struggle sort of across the state. There is definitely a deficit in affordable housing, but knowing what your resources are for your community is going to be helpful. We don't expect you to be experts in everything. You don't need to be. You just need to connect to the right community partners. Mental health. So this is looking at community service boards and beyond. So we want you to think of culturally competent mental health services. Many of the survivors that we work with, many of our participants are African Americans. So we want to look at providers that are, number one, culturally competent, and number two, that look like our community. They don't have to, but it does help. There is a taboo in the African American community with reaching out for mental health help. So to have somebody who really understands that struggle might help connect your patients. Food pantry locations, knowing where they are, they often have handouts that you could have on hand to give to somebody so that they could find their local resource. And then unemployment information and referrals to workforce development. There are actually a lot of people that are still hiring right now. It's just making the right connections. Go to the next slide. So some other things that you can do today. One of those is really looking at your local philanthropic organizations or foundations and looking at, asking them, are they investing in violence prevention strategies? And if they are, would they be willing to help support a crisis fund for patients? So crisis funds are just some extra money that you have on hand that can provide immediate relief. It's great to be able to provide resources and to connect them to those community services, and that's what we should be doing. But if you have a patient who needs to put food on the table tonight, being able to hand them a gift card or to be able to put in an order for grocery delivery can be life-changing. So having those funds on hand is really important. You may also look into your hospital auxiliary funds. I know VCU does that. I assume there may be other hospitals who also provide some grants within their hospital system as well. Work with your social work and case management departments. I know nurses, physicians, it's tough to find the time to really be able to sit down and work with a patient one-on-one, but your social work and case management departments have more of those abilities and probably have a lot of the resources already at their fingertips. So it's really connecting and seeing how you can work together to better serve your patients with community violence. And then lastly, learn about the risk and protective factors that are linked to violence, which makes some populations more vulnerable to victimization and perpetration. I know I'm running out of time, so I'm not going to go into all of that. We will save that for our June 3rd presentation, where we will talk more about what those risk and protective factors look like and understanding more about the root causes of violence. But I do encourage you to go to the CDC's website, even the WHO. They have some great information that can help you determine what that looks like. And then lastly, what can you do to make a long-term impact? So we're talking today about COVID-19, but we know at some point COVID-19 will be long past us, we hope. So things that you can do at your hospital. Advocate for violence prevention programs like HVIPs, like we have at Bridging, or that we have at VCU, like Bridging the Gap. Seek out the expertise of other institutions. We are available for you. Reach out to me. I am more than happy to talk about this with you. I know Davis mentioned this at the beginning. There may be funding opportunities that are coming down the pipeline as well that make your hospital a great site to be able to operate when it's something like this. Integrate the hospital with your community partners that are tackling violence prevention. So start making those connections with your community partners. They're out there and they want to partner. They want to serve in the same way that you do. Most of us have the same goals. In the community, understanding issues of violence as it relates to your community. So like I said, doing that research, looking at your data, looking at your community more in depth, looking at social determinants of health. Getting involved in local initiatives that are focused on violence reduction and prevention. There are lots of coalitions out there. I know in the Richmond area, we have the Inspire work group, and that work group is a collaborative of 45 community partners that are focused on reducing violence within the city of Richmond. Everybody is coming to the table to share a goal, to share data, to work together, and to work with our community members as well. They are important members at the table, as well as our young people. And then lastly, advocate. If you have the ability, advocate for local, regional, and statewide policy and system changes. It takes a top-down approach to make long-lasting change sometimes. And that is all I have. I would like to turn it back over to Davis and to Bonnie and Ruth.
Thank you, Amy. I really appreciate that great information. We are moving very quickly now to Ruth, who I hope we all can hear. So Ruth, take it away.
I hope we can hear.
Yes.
I hope you can hear me. You got it? Okay.
Yes.
Good. Thank you. Sorry about that. Just very quickly, I'm Ruth Micklem with the Virginia Sexual and Domestic Violence Action Alliance, and I'm the Community Initiatives Manager there. And I've been working with victims of sexual and intimate partner violence for about 35 years now. So I'll leave you with that and just sort of talk a little bit about what's happening and what are some of the things that victims of intimate partner violence may be experiencing now with the COVID-19 issue that may not have been going on previously or actually weren't, and why it's important right now for hospitals and healthcare providers to be paying attention to and having conversations with folks about their relationships. So one of the things is the increased isolation, because folks are possibly staying at home or their usual support systems are not able to get out and reach out. There are additional stressors, so people's tension levels are much higher, and there's this sort of underlying anxiety that we're all experiencing that for victims of violence is even heightened more. They may have children at home, other dependents they're taking care of. They may be having to go to work and leave their children with abusers, so a lot more tension and stress is sort of going on out there. There's the co-occurring danger to children. So we know that child abuse reports have increased since March, and there's some concern that victims of violence trying to protect their kids or having increased anxiety about their kids' safety is an issue. There aren't the usual relief valves like work and friends and family and being able to access public spaces like libraries. So that's a big shift for folks. The abuser may be at home all the time or going in and out to work, and the possibility and the heightened anxiety around bringing illness into the household. There's increased financial insecurity with folks out of work or not knowing when they'll be able to go back to work. And there's the greater access to firearms. So one of the things that I was sharing with folks yesterday was some statistics around firearm sales. And just to let folks know is that the month of March in this country saw the greatest number of recorded background checks for firearm purchases. So we know that there are more firearms available and out there for folks. You can go to the next slide, Davis. So also what we know is that the violence or the coercive control that abusers or batterers use shifts a little bit, and there's some that victims will be experiencing and are experiencing that are directly related to COVID-19, and that they may be talking with you about or mention things. So just want to share a few of those. They're experiencing threats of or accusations about infection, demands from the abuser to use or not use personal protective equipment or not having it available, belittling the use of PPEs, making somebody feel inadequate or bad for not using protective equipment, accusations of not taking appropriate care to avoid infections. So in other words, I'm not going to let the children come back to your house because you don't know how to take care of them or you can't protect them from infection. Threats of cutting off access to insurance or medical care, which is something that happens already, but even with the heightened anxiety around being sick, that's sort of raised the parameters a little bit, and demanding outings or other discouraging social behavior. So either making somebody go out and be around people in close proximity or not allowing that. So just a lot of different uses that an abusive person may use to impact their victim as a result of what's happening now. Some of the additional barriers that are more systematic and out in the community is the lack of access to law enforcement. So officers, while they're trying to do their best job, are only probably going to be responding to the more severe cases of violence. So we're seeing reduced interventions, reduced arrests, not much assistance for firearm removal when that's an issue. People have fear of contacting law enforcement. So it's just sort of increased during the current time. There's a lack of access to courts because the courts are having limited hours. So access to protective orders, inability to get firearm release. There's extended waiting periods for arraignment. So if somebody's arrested, they're often being brought in and given a court date three months down the road because the courts are backed up. And there's a lack of access to other forms of support like friends and family, and being able to get in touch with or stay with friends and family because of the additional tensions and isolation. There's an increased likelihood of lethality. And there's also fear of the healthcare environment due to COVID. So where folks might have come in for to deal with a healthcare issue, they may not want to come in because they can't have their family with them or friends with them. So just really raising up of the barriers and the issues that folks are facing right now. Next slide. Bonnie, I'm going to turn that one to you. Maybe.
We're good? Okay. So I wanted to tell you from a boots on the ground kind of perspective, forensic nurse perspective, what we're seeing. To tag on to Ruth's point about patients being afraid to come to our healthcare facilities, we had a patient that actually called us from her car, and she was being so triggered by the trauma of seeing everyone in the isolation gowns and the masks and the police standing at the door when we were, first doing our visitor screening and so forth at the emergency department. They had security there, that she was so triggered she couldn't come in. And thankfully she called and said, I'm here, I need help, but I'm just so afraid of everybody that I see there at the door. And so we made arrangements to take her to a side door and allowed her to have an advocate with her, a family member advocate, as well as one of our HVIP advocates, and helped her through that process. So this is a real challenge for healthcare providers. So some of the things that we're seeing, when Ruth talked about increased lethality, the patients that we are seeing who are victims of domestic violence and IPV, they have more injuries, and the injuries that they have are more severe. And partially, I think the reasoning behind that is that if you can imagine living in a home of violence, it's like a pressure cooker, right? And usually these victims of violence have ways to let a little bit of steam off. Maybe they'll leave, they'll go away for a few hours, they'll calm the offender down, they'll calm that situation down. But right now they don't have that. So they're stuck in that pressure cooker until it builds, and then it just kind of blows, is what they're telling us. That it's just these extreme reactions of violence. And so they're getting hurt more. The other thing is, I think that even once they were hurt, I think they were hesitant to come to the hospital. They were afraid, what was going to happen to their children? Would they be allowed to have somebody come to the hospital with them? What's going to happen? You know, the old saying that the devil you know is better than the one you don't. We even had victims say to us, well, at least I know if I stay here in my house, I've got, you know, shelter even with this offender, which is better than being out on the street with my kids. So they're having to make some really tough choices. Law enforcement is telling us that they are seeing increased numbers of children being solicited online. Makes perfect sense, right? How many kids now are online doing their learning and their modules through school, and they're doing their research, you name it. And so that makes them perfect targets right now to be preyed upon. Increased delayed in reporting, we are absolutely seeing that. We're seeing that with our domestic violence. We're seeing that with our child abuse cases. Everybody's trying to hang on and not maybe rock the boat, sadly. Something we've seen recently more so than I have in the past, and that is offenders who are using reproductive coercion. For example, you can't get your birth control pills filled, or I might use a condom or I might not, and that is a threat that they're using against the victims. If you don't do this, then I won't use a condom, and you may become pregnant. And I'm hearing more of that than I ever heard before. It's absolutely another control mechanism, but it's just coming around a lot. The one thing that I have told people before that haunts me the most about this pandemic, there's lots of things, but the thing that haunts me the most is the cases of child abuse. The schools and guidance counselors and teachers and daycares are safety nets for our kids. And when they are not in those environments and we don't have those extra sets of eyes looking out for our kids, these are kids that are being abused right now, and they have no one to tell and nowhere safe to go. And so my real worry is going to be the pandemic of violence that comes after the pandemic of COVID. And I don't want to sound like an alarmist, but that really does worry me about what's going to happen with our kids. So I wanted to give you just a little teaser, so to speak. Ruth and I will be doing the next presentation in a couple of weeks, and we'll go into a little bit more detail. But one of the things that we are seeing more of in our cases of domestic violence is strangulation. And in 2014, Virginia changed the law so that strangulation is a felony in Virginia. And I think it's important for healthcare providers to know about the continuum of violence with strangulation. And so what we find in patients who are victims of violence is it doesn't immediately start with strangulation. There will be verbal abuse. There will be hitting, slapping, punching, strangulation comes toward the end of the continuum, and then domestic homicide or homicide. Victims of victims of strangulation, if they stay in that relationship, can be as much as 800 times more likely to be a victim of homicide because of that continuum of violence. And so we'll talk a little bit more about that in our next presentation. But if you'll move to the next slide there, Davis, thank you. One thing I did want to share with this group is, because there is this new law, there is additional evidence that can be collected and that is needed in court for these patients. And so it's important for your healthcare facility, if you do not have a forensic nurse program, to find out who in your community, or who is a partner, or who another hospital or healthcare system that has forensic nurses who can perform a forensic strangulation evaluation. There can be swabs of the neck of the patient. There can be photographs taken. We do a symptom checklist with these patients of any symptoms they had before, during, and after. And it's a very detailed evaluation, but becomes very critical when it comes time to court to show the strangulation occurred. Davis? And the reason that evaluation and those symptoms and having an expert witness who can testify to that is so important is because of 50% of our patients have no findings whatsoever. It is not uncommon for us to get calls from law enforcement, EMS, even attorneys who say, well, you know, he or she or the person said they were strangled, but she had no injuries, so I'm not really sure what we're going to do with the case. We have to educate the courts and everyone that the majority of people who are strangled do not have any external findings. Not to say they don't have any findings, and not to say they don't have any symptoms. It's just not going to be stuff that you can see outwardly. And so it's really important for us to have a plan in place. So for those of you who do not have a forensic program, what resources do you have? And if you have a forensic program, has it been impacted by COVID? Are there alternative plans that have been put in place for those victims of violence when presenting to a facility? I'll give you another example that happened to us. We had a patient come to one of our COVID screening stations at the front of the hospital and told the screener, I'm in danger, I'm a victim of domestic violence, and the person who hurt me is right here with me, and whispered, can you call 911, I need help. And so the COVID screener and everybody there reacted very quickly. We got the person to safety, and things are taken care of. But it's important that you know that there are going to be people coming through your screening tables who are victims of violence. And what do you do, and how do you react to those? And if your facility doesn't have a forensic program, what is the plan, right? I'm not someone who is a proponent of having a forensic nurse at every single hospital or facility, but I think if you don't have forensic nurses at your facility, hopefully someone in your community does, or you have a relationship with a program, and so it's a seamless transfer for those patients who need those services. Go ahead.
Okay, thanks, Bonnie. So just want to talk a little bit about what can you do and how do you engage in conversation, or how do you screen for folks for intimate partner violence? So one of the things that we really encourage is universal screening, because intimate partner violence is so prevalent. It's best to ask everybody questions and not just somebody that you may suspect. And we're going to, and again, we're going to be going deeper into universal screening and different ways of screening in the next webinar. One thing I do want to say about screening, and it's also really just engaging in a conversation, engaging in a dialogue, but to really think about how you can get a victim away from their perpetrator. So very often, what it looks like is this really caring partner who just wants to be there for everything, and that's sort of a red flag for possibly coercive control. So one thing that we do really stress when we train around developing screening processes is how do you develop a protocol to be able to screen people individually, and we will talk more about that again. One of the ways to do screening is to offer just an information card. And one of the things we found most recently is when you approach screening from a healthy relationship standpoint, like, you know, intimate partner violence is very prevalent. We want to talk to everyone about their relationships. Do you feel supported by your partner? That is a way that you can quickly engage somebody in a dialogue. And then what I have on this next bullet is just sort of a script that you can use that's very quick, and it enables you to pass along information to someone. So you could have a card with a hotline number on it, or another way that somebody can reach out for community support, and just give it to everyone. Because intimate partner violence is so prevalent, we offer these cards to all our patients. You can keep it, or you can pass it along to a friend or family member. And that just really makes that connection for folks. We really do want folks to listen for high-risk concerns, such as access to firearms, prior strangulation, or threats of suicide or homicide. If somebody comes in and says, you know, my partner choked me, that's a red flag for a high risk. You really want to pay attention to that. So what do you do when somebody says something? I know a lot of folks get very nervous about asking questions because they don't know what to do, or they feel like they have to fix everything. You don't have to fix everything, and you really can't. It takes a village. So here's what is the important things to do. Listen, really listen to what the patient is saying. Thank them for sharing intimate information with you. If they share something with you, just acknowledge that. Let them know it's not their fault. Tell them that you believe them and that they don't deserve this. You can let them know they're not alone. This happens to a lot of folks. You can share that you're concerned for their safety and the safety of their children. Or if you don't know what to say, it's okay to just say, wow, I don't know what to say right now. I'm really glad you shared that with me, and I want to connect you with someone who can help. So you can go to the next slide.
So Ruth and I wanted to share with you a couple of resources, and so we can just, Davis, go quickly through these. One of them is the Safe TA, has wonderful resources, policies and protocols, sample documentation tools. The next one is Futures Without Violence. Again, another wonderful resource for healthcare providers on how to take care of patients who've been victims of violence and set up policies. And then here's some other resources. Ruth, you want to share?
Sure. So almost all jurisdictions in Virginia have a community-based domestic violence or sexual assault crisis center that is available to them. So that's one of the things that you want to find out. Who is your local domestic violence or sexual assault agency, and make a connection with them. You can find that out by calling the statewide domestic violence hotline at 1-800-838-8238. That hotline is available 24 hours a day, 7 days a week. It's there for professionals as well as for victims and friends and family members, but that is a place you can call and get a number to your local program. And we want to get you thinking about making warm referrals. So instead of just handing somebody a phone number, that you have made a connection with that local program, and you may be able to pick up the phone and call somebody there and then hand somebody that phone, so that you're really helping to make those connections. And then we really want to encourage follow-up. So either you are checking in with that patient, or you're making sure you're working in partnership with an advocate and they are checking in with that patient. So those are just some of the things that you can do to facilitate a connection.
And then just one last thing I wanted to share. We'll also at the next presentation talk about mandatory reporting. If you have a competent adult, domestic violence is not a mandatory reporting. I know that there are healthcare facilities that still call police when the victim of violence comes in. There are very specific laws around when you do and when you don't call, and we'll go into those further on the next one. Okay, Davis, thank you.
All right. Thank you, everybody. I know we are over time, but I know that was very ambitious of us to try to cover so much information in such a small amount of time. But I do want to extend a thank you to these three ladies for such an incredible amount of information and their expertise and their experience. And I want to thank you all for joining us for this time. We don't have enough time, unfortunately, for questions. There weren't really that many in the chat. We are more than happy to follow up individually. I do want to leave this slide up as we exit, so you can contact each of us as needed, because we do want to make sure that your questions are answered if you do have questions about an individual topic. I do want to thank each of you for taking time out of what is a crazy time, for joining us for what we think is a very important topic, and we hope that you did take something away from this webinar and are able to apply it. And please remember that we are having 2 more webinars on May 27th from noon to 1, and that's going to be talking about sexual and domestic violence. And then on June 3rd from noon to 1, and that's going to be talking about gun violence and then community violence as well. So really look forward to speaking with you all. Again, thank you so much for joining us. We look forward to speaking with you all then. Thank you.
Thank you.
Thank you, everyone.
Thank you.